Good afternoon. Welcome to the second in our series of CPD accredited talks on the early warning signs of childhood cancer and the different childhood cancers. My name is Audrey Ludick, and I'm the Program Development Manager for CHOC Childhood Cancer Foundation in South Africa. CHOC's mission is to support children and teens with cancer and life-threatening blood disorders and their families, improving early detection and facilitating effective treatment. CHOC offers comprehensive child and family support through psychosocial, emotional, and practical support as we augment pediatric oncology in South Africa. In September 2018, the World Health Organization launched the Global Initiative for Childhood Cancer with the goal of reaching at least 30% survival rate for children by 2030 while reducing suffering. One of the most frightening things that the parent can hear is your child has cancer. Therefore, in 2010, CHOC started our training and education program to train healthcare professionals, healthcare workers, traditional healers, and communities on the early warning signs of childhood cancer. As part of our awareness program, we will be hosting monthly CPD accredited talks on the different childhood cancers and the early warning signs thereof. We believe that early detection saves lives. We want to thank the members of the SACCSG who voluntarily give their time in support of these webinars. These accredited webinars on childhood cancers are to increase disease knowledge of healthcare professionals and in doing so, to reduce the mortality and morbidity of children with cancer. Professor Jennifer Geel is Head of Pediatric Hematology Oncology at Charlotte Maxeke Johannesburg Academic Hospital in South Africa, and former chair of the South African Ministerial Advisory Committee on Cancer Control and Prevention. She is passionate about improving the survival and quality of life of children with cancer in South Africa. She spent 2 years in clinical research settings in Cape Town and London before specializing in pediatrics and subspecializing in pediatric oncology. She has a strong interest in stem cell transplantation and is the principal investigator of the South African National Hodgkin's Lymphoma Group. Prof Geel is the Secretary General of the Africa Division of CHOC and former co-chair of the Education and Training Working Group of CHOC Global Health Network. Prof Geel is an executive committee member of the South African Childhood Cancer Study Group and a member of the South African Stem Cell Society. Each of these societies is responsible for research in pediatric care. Currently, she is involved in research concerning Hodgkin's lymphoma, retinoblastoma, germ cell tumors, neuroblastoma, rare tumors, and COVID effects on referral to specialized centers. She founded a non-profit organization, CARE, Cancer Awareness Research and Education, for kids with cancer to fund collaborative research in South Africa. Please welcome Prof Jennifer Geel to do her presentation today on bone tumors in childhood cancer. Jennifer, welcome and thank you so much. We are looking forward to listen to your presentation.
Hi, Audrey. Thank you very much. Would you like me to share video as well, or can I just go ahead on the talk? Okay, I'm putting video on so you can all see me squeaking at my own slides. So thanks very much, Audrey and CHOC, for the invitation. We work very closely with CHOC and we really couldn't do a lot of what we do without CHOC. So she gave you a list of things that CHOC does, which may sound sometimes a little bit fluffy, but things like psychosocial care, giving accommodation, giving transport, these are essential for keeping our patients in treatment. So it the work that CHOC does actually helps with our survival rates. So I'm going to be talking about bone tumours in children. If you've got questions, please put them in the chat and we'll get to all of them at the end. I've left a bit of time for questions, so no question is too big or too small. You can ask anything you want and hopefully I'll be able to answer most of them. And it's not changing. I'm just having a problem with moving to the next slide. Okay, there we go. So what I hope that you'll get from this talk is firstly to recognize signs of bone tumors in children, to be able to perform the appropriate initial investigations, and then most importantly for us to be able to know how to refer rapidly and appropriately. Then later in the cancer continuum, to manage patients if they're referred back to you, and then a little bit about long-term follow-up. So I'm not intending to make you an expert on this. I'm certainly not an expert in bone tumors, but I'm going to share what I do know with you. Childhood cancer, we know, is rare, but there are approximately 350 new cases of childhood cancer per year in Gauteng. So these patients will go to Chris Hani-Barra, they'll come to us at Charlotte, they'll go to Steve Biko, and they'll go to the private practitioners as well. Many of these patients will present with advanced disease, and many, if not more than half, have presented to health services several times over in the preceding weeks or months before they actually reach us. And this often means that these patients present to us with late-stage disease. And these delays obviously make treatment more difficult and decrease the chances of success. So when I'm speaking to you all out there, I'm hoping that you will be able to pick up these children early, because most childhood cancers can't be prevented, they can't be screened for, but they can be detected early, and we will take them as soon as you find them. This is a slide on the incidence of childhood cancers, and the incidence ranges all over the world, and it's got a lot to do with how data is captured, the state of the healthcare system, you know, if these patients are picked up and referred, and then if they're actually captured on the various tumor registries. So again, CHOC has been supporting the South African tumor registry, which keeps account of all the cancers in the country over the last few decades. So we'll be talking about osteosarcoma and Ewing's sarcoma, which really don't make up a large proportion of all the cancers we see, but they do make up a big proportion of bone tumors. And in teenagers, they make up a big proportion of these cancers. So for most of you, if you're pediatricians, you should see at least one new case per year. And most GPs will see a handful of cases per career. And we know that many of these cases are not being diagnosed, they're actually missed, so they're not referred to us. This is just a very plain schematic of what to do if you see a child suspected with a bone tumor. So just in brief, they'll present with bone pain and or swelling. And if there's not an obvious cause, like a fracture, the next step is a plain X-ray. So obviously, if you have a child with a fracture, you'll do an X-ray anyway. This is then divided into lytic lesions on the right or solitary lesions with characteristic appearances on the left. Most of these are benign, and there's an explanation of what they may look like. So if they have a sharply marginated edge and the lesion itself is radiolucent, then the next thing you should do is a thin section CT and follow that up with a biopsy. And these cases may be osteochondromas, osteoid osteomas, which can actually cause a lot of pain, osteoblastomas, and fibromas. And then if the lesion is eccentric and it's destructive with metaphyseal expansion, then they're often non-neoplastic lesions, so you won't need to worry about them. But if you look carefully, almost near the top of the diagram, the primary care provider's role really ends at referral. So after they've done a plain X-ray and they see something suspicious, they should refer immediately to an expert. If there's a periosteal reaction, then you need to be concerned. You'll do a CT and MRI and staging depending on what the lesion is. And these lesions will either be osteosarcomas, Ewing sarcomas, or if you're lucky, osteomyelitis. Now, obviously, for the child involved, osteomyelitis, they won't consider themselves very lucky. It's a long course of antibiotics, often with multiple courses, but it's better than having a bone tumor. If there's no periosteal reaction, then the specialist will do further workup, and these lesions might prove to be neuroblastomas or histiocytic disorders. This again is a very brief overview, and I think it's what a lot of us remember from varsity, where we were taught you have to distinguish between an osteosarcoma or a Ewing sarcoma, and I'm sure many of you will have things in your head like Codman's triangle, onion skinning, periosteal reaction, etc. The truth is, a lot of that doesn't really matter unless you are the specialist involved. But very briefly, osteosarcomas are the most common primary bone tumor in children, and they're normally in older children. Ewing sarcoma is the second most common bone tumor in children, and they're generally in slightly younger children. The pathology in osteosarcoma is basically abnormal bone, so osteoid tissue, whereas Ewing sarcoma is an undifferentiated small round cell tumor. And I'll talk a little bit more about those soon. Osteosarcomas generally occur around the knee, so it can be the distal femur or the proximal tibia, but it's almost always in long bones, and it originates in the metaphysis, whereas in Ewing sarcoma, it's diaphyseal, metadiaphyseal in long bones, can also be found in the pelvis and the lumbosacral spine. And risk factors, osteosarcoma does have known risk factors. So if you've had a hereditary retinoblastoma as a child, young child, and you treated with chemotherapy and radiation, you may present a few years later or a few decades later with an osteosarcoma. Children who have benign bone conditions such as fibrous dysplasia, these may later present as osteosarcomas. If you've had radiation for any cause, you can develop an osteosarcoma. And the strange thing about this is that it's not always in the area of radiation. It's often in a completely different area. And then people with Li-Fraumeni syndrome, which many of you may remember, is a hereditary cancer disposition syndrome, which results as a mutation in the P53 gene. Ewing sarcoma, the only risk factor that people have been able to identify is that it's more common in white males. So let's start, we'll talk about the two different tumors completely separately, and then I'll bring it back together at the end. Osteosarcoma is characterized by a production of osteoid by malignant cells. The incidence is round about 3 per million, and constitutes about 3% of the pediatric malignancies that we see. So this is just in children. In adults, it's much less. It's about 0.2% of all malignancies. And it's the most common non-hematologic primary malignancy of bone. It's the third most common cancer in adolescents, but if a child presents with a bone problem and you suspect it's a cancer, it's most likely to be an osteosarcoma. Epidemiology, it can occur at any age, but most of them occur in the teenage to adolescent to young adult period. And it is found slightly more in males, and definitely in our populations, it's found more in Black children than in white children. The skeletal distribution is quite important. So as I said, it's in long bones. So most of them will be around the knee. A small proportion will be around the hip bone, so proximal femur, head of the femur. And those ones can be very difficult to treat because you have to excise them to cure them. And then a smaller proportion will be around the shoulder girdle, and then an even smaller proportion will be in the mandible. Clinically, they present as painful bone masses. Now, in high income settings where people have good access to healthcare and don't feel intimidated often by the healthcare system, these children will present often with much smaller masses. So they may even present with bone pain without a mass. I often think of the private sector in South Africa as more like high-income countries, whereas the state sector is more middle income and low income medicine. So if you are a private practitioner, you may see these children when the masses are very small, or even when they seem clinically indistinct. Patients can have swelling. They may present after trauma. So they'll have some sort of a trauma that is not actually very significant. Sometimes it is significant. So I remember one patient we had was kicked by an ox, which we haven't had that presentation again, but it wasn't the ox that caused the problem, it was the underlying osteosarcoma. Then they may present with pathological fractures. So what happens is they have a fracture that occurs after really minimal trauma. They may fall off a bike or, get kicked by their brother, but then they actually present with a tumor. So no matter how hard your brother kicks you, you should not get a fracture from it. These malignancies really metastasize early. So the figure of 20% of clinically detectable metastases, that comes from high-income countries. But in our setting, at the patients we've looked at, actually 75% of the patients present with metastases. So that shows that these tumors have been growing for a long time. Constitutional symptoms are things that people often associate with cancers, but they're not common in osteosarcoma. So these patients, especially in the beginning, will be absolutely well. They will have no other symptoms at all. So the first investigation that you'll do is a plain X-ray. And these are some examples of X-rays from different patients with osteosarcoma. So you'll see destruction of both the medullary and the cortical region, and you'll have a wide zone of transition. So it's not a very discrete lesion. There's often a permeative or a moth-eaten appearance. And then there's an aggressive periosteal reaction. So you'll see the periosteum is often a little bit whiter and it may be lifted. And Codman coined that term, the Codman triangle. There's the sunburst type. Now, honestly, I don't find any of these particularly useful because most of these patients present to us in this country much later. But if you look at the top left image, it looks like an explosion of bone. It looks like someone has set off an explosion in the middle of that bone, and it's climbing out like the typical crab of cancer. You see the bottom left, there's a pathological fracture. So if you look, there's not too much to see on that bone. It doesn't actually look that abnormal, but there's an obvious fracture, and that was after minor trauma. And then here on the bottom right, again, is this sunburst appearance, and you can see a little bit of periosteal lifting on the left. Some of these patients may have lamellated or onion skin reaction, but that's actually quite uncommon. And then they may have a soft tissue mass, which may be evident on the X-ray. So then the next important imaging to do is CT, if you're going to do staging. So really the most appropriate imaging is MRI. But if you've done a CT, it may be useful for local delineation of the tumor when the radiographic appearances are confusing. So let me just go back. So for example, that the bottom left image where you've got a pathological fracture without much obvious abnormality, that might be a good one to CT, but you're going to do an MRI anyway. So you may as well not waste your time and the patient's money and the medical aid's money. You may as well just go to MRI. But CT is useful for detecting pulmonary metastases. So if you look top left, there's some little helpful arrows there, and those show quite small lesions, which are quite discrete and distinct, and they're basically calcified. And then on the bottom is an image from a patient who presented much later. So they've got much bigger metastases. They've actually got what's it called? A pneumothorax and a pleural effusion. So that patient is in real trouble. So here's a picture of an MRI. So if you remember what those X-rays looked like, they didn't look too bad. But when you do the MRI of these lesions, you can really see the extent of the disease. And it's a heart-stopping moment most time when we see them. The tumor is generally quite heterogeneous. There's generally a soft tissue mass, and you may even see intramedullary skip lesions, which you almost never see on X-ray. So bottom left is an image taken from long ago. This was one of my favorite patients. He was 16, he was an A student, he was acting in the school play, and he fell off the stage and he hurt his arm, and he thought that that was why his arm was sore, but it was actually because he had an osteosarcoma. And yeah, it does look pretty bad, but it looks really terrible on the MRI image on the right. Diagnosis, the most important thing about the diagnosis is that it must be performed by a very experienced orthopedic surgeon. So it can't be the guy or girl who's just out of varsity, who's quite keen to try new procedures. It can't be the person who does a lot of spinal surgery and never touches a tumor. It's got to be a tumor surgeon. So you've got to find the right person. And luckily, we've got a few of those in Joburg. It's important that it's performed in a tertiary center if at all possible. And you really have to try hard to try and get the same surgeon to perform the biopsy as the person who will do the definitive surgery, because they need to excise the biopsy tract. Now, when we do amputation, this is not necessarily very important because you're chopping off the whole tumor as well as the biopsy tract. But if you're going to perform limb salvage procedures, it's very important that you get that tract out. Otherwise, the patient will relapse because that tract has basically been contaminated with tumor cells. Now I'm having problems with pressing the button again. So I'll just be patient for a sec. I apologize. So just looking at that nice image, you can see the needle entering from the right. And this is a CT guided image. You often, CT guided biopsy, you often don't need CT because the lesions are so big, you can't miss them. Okay. There we go. Right. So once the orthopedic surgeon with high volumes has done the biopsy, he or she will send it off to the lab, and the lab will then classify it into 4 histological subtypes. The one that we see most commonly is conventional osteosarcoma, which is divided into osteoblastic sarcoma, chondroblastic, and fibroblastic. There is a little bit of difference in prognosis between these different histological subtypes, but again, in our setting, it doesn't make much difference because these patients come with such large tumors that we've long passed that pattern. The next subtypes are telangiectatic, which is common in adolescence and early adulthood, parosteal, which is located in the bony cortex, and it's easier to cure than the conventional subtype. It's rare. I think we've seen one in the last 15 years at Charlotte. And then periosteal, which is considered to be low grade. It generally occurs in older patients and has a more indolent course. So we don't see this in children. With every solid tumor, the next important step is staging. And the staging leads you on to the prognosis. So we start with laboratory tests. Alkaline phosphatase and lactate dehydrogenase, which are both enzymes produced by bone. They're generally very high in patients with osteosarcoma, but if they're in the normal range, that's a good prognosis. It's really a measure of the volume of tumor. So if you look at the bone scan, bottom left, that's the kind of tumor that we see at Donald Gordon. more frequently, or the kind of tumor that is seen in America or the UK. So you can see there's a very dark spot. That's the primary lesion in the distal femur. You can see just above it, there's a little dark spot, which could be a skip lesion. And then you'll see lots of other normal symmetrical dark spots. That's increased uptake of the radiolabeled tracer. And that's physiological. That's normal. You might get a little scare the first time you see one of these, because the patient, might have a little flare around the wrist, and you'll think there's a skip lesion there or a distant metastatic lesion. But that's often just from the drip. So you've got to actually know which side the IV line was inserted, because there'll be a little bit of radiolabeled tracer there. And then if you look at the bone scan on the right, that's more the kind of patient that we see fairly frequently. You can see the primary mass is enormous. It's really huge. I don't think you even need the arrows to find it. And then you'll see in the lungs, multiple round discrete lesions. Those are pulmonary metastases. This patient is in a lot of trouble. So you've got to do a CT scan as well. So you can't rely on your bone scan to look for pulmonary metastases. The CT is the most sensitive image to do. And then you try and prognosticate, because you have to tell these patients something. Are they going to live? Are they going to die? Are they going to keep their leg or their arm or whatever? So some studies have shown a bit of a prognostic difference with sex, but it's not really a firm prognostic factor. The site does make a difference, because you have to be able to excise the tumor. So if it's in an area that can't be excised, you cannot cure the patient. The size is very important. So if the tumor is more than 8 centimeters or 200 mils in volume, that is a very poor prognostic factor. And those patients are much more likely to die. And then, as we mentioned, if the levels of the tumor markers LDH and ALK-Phos are high, that's also poor prognostic. And then if you have pulmonary and or bone metastases, you're also in trouble. So unfortunately, in this country, if you have pulmonary metastases, you have a 0% chance of survival. So that's why it's so important to refer these patients early. And then the next important prognostic factors, so all of those, the first 1, 2, 3, 4, are important at presentation. But we then use the extent of necrosis after preoperative chemotherapy as another prognostic factor. And we've shown quite clearly in Johannesburg, and it's been shown in many other studies, that extensive necrosis correlates very closely with prognosis. If you've got 95% prognosis, necrosis or more, then you have a good chance of survival. It's not excellent, but it's better than if you have a less than 95% chance of survival. Management is multidisciplinary, so we can't do this alone. We start off with neoadjuvant chemotherapy, and I've listed some of the agents there because you need to know about the main side effects, the long-term side effects of these agents. So there's methotrexate, which is causes more short-term problems. Ifosfamide, I'll go into the long-term side effects later. Cisplatin, etoposide, and then people may use gemcitabine, and doxorubicin is a standard. The surgery, the aim of the surgery is to completely excise the tumor. You have to take it all out. If you leave anything behind, the patient will not survive. So amputation is probably the most useful tool for the surgeon, but it's obviously the most devastating for the child. So the next option is limb salvage. Some people call it limb sparing. Orthopods think differently to pediatricians, so they will call it reconstruction. And then there's something called rotation plasty. So just a couple of words about limb salvage. What the surgeon's trying to do there is to excise the entire tumor and then leave a functional limb. So they may do something like an entire knee replacement, so a completely prosthetic metal replaced joint, or they may use cadaveric bone, so they'll take a piece of bone from a cadaver and then use it as a bridge between the hole, you know, to bridge the hole that's been created by removing the tumor. They may take what they call non-essential bone. So it'll be something like the fibula or a rib, or maybe even a piece of clavicle. And they'll use that as basically as a scaffolding for new bone to grow on top of. And then the other really quite gruesome thing is to take out the bone, the diseased bone, completely scrape it free of all tumor, and then radiate the heck out of it. So normal radiation, so for example, if we were going to radiate someone's brain for leukemia, we'd use a dose of maybe 12 gray. But there you would use a dose of 80 gray. So it's a really high dose. So they really do kill the tumor. But then obviously you're left with completely dead bone. So what they're putting back is something that is anatomically perfect because it's the person's bone, but functionally it doesn't have anything. So again, the new bone needs to populate this framework, this skeleton, and create something that is functional. And that takes a long time. So rehabilitation from that process is quite extensive. Once you've done your definitive surgery, you give adjuvant chemotherapy as well. So what you're trying to do there is you're trying to mop up any micrometastases. So it has to be given for quite a long time, a few months. And then really, really important is rehabilitation. You can't take a healthy child in what they think of as the prime of their life, chop out a really important part of them, and not work very hard to rehabilitate them, because all your efforts will be done in vain. So psychosocial care is absolutely essential. And again, that's where CHOC is so helpful to us, because they provide social workers in almost all the pediatric oncology centers around the country. And these kids need a lot of help with body image, with all sorts of things. Again, I'll talk about it a little bit more later. They need physiotherapy in the short term just to get back on their feet, to start using their limbs properly, or they may need physiotherapy to learn how to use crutches. If they qualify for a prosthetic, then they need good prosthetists, and we have those at Barra. But it's really, it's quite basic compared to what the fancy things that you see on TV and in movies. So those almost pretty prosthetics cost $500,000, $1 million rand, sometimes more. And kids grow out of their prostheses, and they also damage them. So we don't really have that as an option for most of our patients. And then just a word on palliative care. Now, many people still think that palliative care is about end-of-life care, and it's not. To palliate means to relieve suffering. And if you think of a child who was a happy soccer player before, who was doing well in school, you know, thinking he's the bee's knees, and then he develops an osteosarcoma and then has to have an amputation, and has really toxic chemotherapy, loses his hair, loses weight, has really bad mucositis. These are all very common side effects of the chemo that we give. These kids need someone to help relieve their suffering. So they need someone to help with the nausea, help with the pain, help figure out what to do about school, because these kids generally can't go to school while they're getting this intensive chemotherapy. Their parents need help with finances. There's a hell of a lot that goes into palliating the suffering of children treated for bone tumors. So just a couple of words on some of the patients that we looked at a few years ago. over 20 years, there were 64 patients. So these are all children at Charlotte. Their mean duration of symptoms was 90 days. So that means most of them had at least 3 months of symptoms before they presented to us. And most of the patients presented with poor prognostic features. So they couldn't get out the starting blocks. We looked at the kids that we tried to treat with the intent to cure them. So we excluded those who got terminal end-of-life care up front because they were just nowhere near curable. And we excluded those who refused amputation, and there are a few of those. And of the remaining patients, the survival rate was only 42%. So this probably sounds terrible. It's the highest rate reported in South Africa so far, and we could do much better. The causes of death were mainly progression of disease and then treatment complications. So more than 10% of these kids actually died as a result of the chemotherapy and the infections post-chemotherapy. So we've made some changes since the study. We've introduced therapeutic drug monitoring for methotrexate levels, and we're hoping that these changes do make a difference, but it's not a walk in the park getting chemo for this disease. These are some Kaplan-Meier graphs. These are my favorite graphs. I'm a graph nerd. So Kaplan-Meier graphs basically start off with 100% survival, and as time goes on, as you lose patients for various reasons, the graph goes down, and it eventually settles. We like to talk about the 5 and the 10-year survival rate. So the 5-year survival rate for our patients was, as I said, 42%, but the 10-year survival rate dropped down even further. So some of this is just because patients were lost to follow-up, but we've got to remember that children can still die from complications and relapse later on in treatment. So I spoke about chemo response rate. If you look, so bottom left, if you had a good chemo response, that's the green line, you had a higher survival rate. So the 5-year survival rate for those patients was around about over 60%, but it continued to drop. Then if you had a poor chemo response, the survival rate was quite a lot lower. And the orange line, there's always a bunch of patients whenever you do a retrospective study who you just can't get the answers. And the orange patients always do worse. So the ones that we didn't have an answer for did even worse. And the difference was significant, but I must just caution you that the numbers are small. So I wouldn't, put my head on an absolute block for this. We also found that nutrition was important, but again, some of these patients may have come to us really wasted and cachectic because they had such a high tumor burden. So the particular challenges of patients with osteosarcoma, one, late presentation. I've spoken about that quite a bit. Second thing is lack of consent for amputation. So if you can't cut it out, you can't cure it. And there's the obvious fear of mutilation. And then there are also cultural issues with some groups who have prohibitions against surgical removal of any parts of the body. So that makes our job quite difficult. Toxic chemotherapy can cause problems. There's a high rate of relapse with these tumors. And once these children relapse, there's nothing we can do. There is no cure rate. And then cisplatin is a major cause of deafness in our patients. And it may be subclinical. It may be just enough to miss important words at school, or to, if you're lucky, not hear your mother calling you to clean up your room. But you then land up with a patient with a combination of disabilities. So you have to be very careful to mitigate that. All right, let's talk about Ewing sarcoma. So Ewing's is the second most common bone tumor in children. I'm sure many of you were tormented by small round blue cell tumors when you were at varsity, or if you passed through our unit. This is a catch-all name for a group of different malignancies that look just like the bottom right picture, small round blue cells. Now, if you're going to be picky, they're kind of purple, kind of lavender, but to histologists, they call them blue cells. It's a very poorly differentiated tumor. It's of unknown origin. It's thought to be of neural crest progenitor cells, but it's really difficult to tease it out. And then some of you may know about PNETs. So it can seem a little bit confusing, but basically it's a Ewing sarcoma family of tumors. So the big one is Ewing sarcoma, which is in bone. That's most of them. Then you get extraosseous Ewing sarcoma, and then you get peripheral PNET. So that's primitive neuroectodermal tumor. And then Askin tumor, which is on the chest wall. Right, so the epidemiology, again, it can occur at any age, but it's mainly in the teenage years. It's around about 2 to 3 per million of children, males slightly more than females, and white patients more than Black and Asian patients. So just recapping the skeletal distribution of osteosarcoma on the right. Now we have Ewing sarcoma on the left. And these, you can see, are in the middle. So the metaphysis, the shaft of the bone. Then they can be in the hip bones, they can be in the shoulder, and they can be in the ribs. So you don't get them up in the mandible. They also present with pain and swelling of the affected area, but the difference is Ewing sarcoma patients might have systemic symptoms. So they might have fever, anemia, and weight loss. And if you do white cells, ESR, and LDH, they may be raised. So just referring back to this again, don't get your knickers in a knot. Once you've done the X-ray, you can refer to us, but we'll teach you a little bit more just so that you can sound really clever when you talk to the parents, and so that you can test that we're actually doing the right thing. So you'll start off with plain X-ray. You may see lytic or mixed lytic sclerotic areas, and you can see it's quite subtle. You may again have the multi-layered subperiosteal reaction or onion skinning, and then the lifting of the periosteum. And again, there's a wide zone of transition. So on an X-ray, it may be difficult to differentiate, except for the position, you know, the location, the anatomical site. Extraskeletal Ewing sarcoma may have a large soft tissue mass, or they may look completely normal on X-ray, but they may be adjacent to bone erosion, cortical thickening, osseous invasion, or an aggressive periosteal reaction. So there's a wide range. And again, when you do the X-ray, what didn't look too bad, when you do the MRI, what didn't look too bad on the X-ray looks absolutely horrendous. So you can see the entire humerus is just patchy, it's inhomogeneous, it's unhappy looking. And then there's this big soft tissue mass, and it's a very unhappy looking bone. So it's generally got a low to intermediate signal on T1, but a high signal on T2. And then when you add gadolinium, you see how heterogeneous it is with the prominent enhancement. Again, you have to do a CT chest to pick up pulmonary metastases. And this time it'll be soft tissue attenuation, so not a bony lesion. They're generally also well circumscribed, rounded, more often in the periphery of the lung, and they may be of variable size. So you may have quite small lesions and quite large lesions. Again, staging is important. So the main difference in staging with the Ewing sarcoma is that you're going to do a bone marrow aspirate trephine, because it can spread to the bone marrow and you may not pick it up unless you do a BMAT. And then PET CT is gaining more acceptance for Ewing sarcoma, and it's quite a nice modality to use to assess treatment response. So this is a picture comparing a CT scan of the chest. So second image from the left, got to know my left and my right. It looks bad, but if you do the PET scan on the right, you actually pick up more lesions. And the thing with PET scan is that it gives you an idea of the functional activity of the tumor. And then again, if you look bottom left, you can see this big mass, but when you do the PET scan, it climbs out and shouts at you. So I like PET CT because it's good for someone who's spatially not very aware. It really makes it obvious. But you can see if you do serial PET CTs, how that bright yellow decreases and decreases if your treatment is working. So the treatment aims are pretty similar to osteosarcoma. You use chemotherapy to control the micrometastases. You use surgery to achieve local control where possible. Radiotherapy if you can't achieve local control or if you can't get all of the tumor out. Rehabilitation, just as important, and palliative care all along the continuum. The treatment, we use some of the same agents and some different. So the ones that we use in Johannesburg are vincristine, ifosfamide, doxorubicin, and etoposide. And then we give what we call maintenance therapy. So that's metronomic or treatment at lower doses at regular intervals, like a metronome. So we use vincristine, actinomycin, and cyclophosphamide for that. Long-term follow-up is very important because the first thing is the child may relapse. You need to deal with any disabilities that may have evolved as part of the treatment. You may have cardiac dysfunction because of doxorubicin, and that it's difficult. You're not going to hear it with your stethoscope. You need to do regular echoes for these patients. Some of them develop renal tubulopathies. A high proportion of children will grow into adults with multiple psychological issues. So they may have anxiety about the tumor coming back. Patients have coined the term scanxiety, which is the worry every single time they have to have a routine surveillance scan. They worry that the tumor will have relapsed. You've got to be careful about secondary malignancies as well. So the image on the left shows the cumulative incidence of secondary malignancies. As years go on, the incidence climbs and climbs, and it's quite dose dependent. It depends often on how much radiation the patient received. So we try and keep it under the dose that will trigger malignancies, but it's not always possible. And there may be other secondary malignancies. And then patients with prostheses experience a host of problems. Obviously, the cost is an issue. The fit, there's pain, there's infection. There's lots of just mechanical problems with it. So these kids need close follow-up and a lot of care. A couple of words on whether to amputate or reconstruct. There's been some research which has shown that the quality of life actually doesn't seem to differ in terms of psychosocial outcomes or achieving endpoints such as maintaining a stable relationship and being employed. So that's quite surprising because we always think, everyone's better off with their own leg, but their own leg or their own arm may be painful or may be infected or may not work as well as it did before. There's also no difference with respect to acceptance of the post-op status, ability to walk, and amount of pain. So that's an important thing just to remember, that limb salvage procedures may be associated with a lot of pain later. There are obviously higher functional scores in limb preserving patients, but the complications were much more common because obviously if you amputate, there's nothing too complicated except the end of the residual limb. But if you have a limb preservation procedure, you've got foreign material sitting there, you've got, you might have limb length discrepancies as the patient grows older. There are lots of things that can happen. And then Local recurrence is thought to be slightly greater with limb reconstruction, but different studies sort of differ on this. And one of the orthopods did a master's looking at Barra and Charlotte, and there was actually no increased incidence of recurrence with limb reconstruction. But again, the numbers are quite small. So I was going to talk about staging, but I think we're actually going to run out of time. So the important thing is just that orthopods like the Ewing staging, which actually doesn't have a stage 4. So we often speak about pulmonary metastases as stage 4. So there's an American Joint Committee on Cancer staging system, which basically looks at the size of the tumor, whether there are regional nodes, and generally there aren't with bone tumors, and whether there are distant metastases, and then puts them into a 1 to 4 staging system. The important thing about any staging system is that it must correlate with prognosis. Okay, so I've spoken about a lot of the prognostic factors. This is an image that we made for Ewing Sarcoma Month, and it's available in Zulu and English. So if anyone wants to get hold of that, you can just contact me. And then the most important thing is survivors, because we want to create survivors. We want to cure these tumors so that people can get on with their lives. In the US in 2006, there were about 250,000 people of the more than 10 million people in the USA who'd been treated for malignancy who had had childhood cancer. So basically what that's saying is that there are a lot of childhood cancer survivors in America. And who looks after them? It's not the oncologists, because we're too busy curing cancer. We need everybody else to take them over later. And increasingly, pediatricians are being called upon to care for children as we have more and more survivors. And there are lots of long-term side effects to manage. So a clever guy called Giuseppe Macera described a strategy of total cure that encompasses medical, educational, psychological, and social aspects. So you've got to do long-term monitoring, prevention and treatment of side effects. You've got to think about studies. You've got to encourage post-traumatic growth. So getting treated for cancer is a very traumatic event, especially if it involves some sort of bodily mutilation. And then we need to work on abolishing childhood cancer-related barriers to education, to employment, insurance, and other social opportunities. So that's obviously not something we can do alone. We need to do it together. Survivors are a major research focus now. We're looking at ways that we can improve their experience. And there are a variety of models for delivering care to survivors, with most centers relying to some degree on shared care. So meaning the oncologist works together with a pediatrician or a GP or various psychosocial professionals to carry on care of these survivors. And then referral pathways. So this is a nice image produced by CHOC, showing how you can refer patients. And what they're really saying is, let's not use the traditional models of going from the community to primary healthcare, to secondary healthcare, to a regional hospital, to a specialized pediatric oncology unit. Let's bounce straight from community to district hospital, and straight from district hospital to specialized pediatric oncology unit. But what I would like is for you to jump the entire queue and just phone us directly. So that's my referral pathway. Just pick up the phone and phone us, and we'll take the patient. You don't have to prove it's a cancer. You don't have to get histology. We will do all of that. We will expedite it. We will make sure there are no delays. So you can call us at any of these numbers. There's an on-call phone, which is staffed 24 hours a day by whichever consultant is on call, and you can email me directly. And if I ever don't get back to you, please feel free to just email me again. So that's the end of my talk, and hopefully there's a little bit of time for questions.
I can't stop my video. Jennifer, thank you so much. That was absolutely awesome. And sorry, I don't know, my video don't want to go on. So yeah, so we'll just look at your beautiful face.
Oh, yeah, you're in trouble.
I can't see any questions in the chat. I have asked people and said that they are welcome to put questions in the chat, but I think your presentation has been so comprehensive that I think you've answered all the questions that the people was going to ask. So yeah, we really admire, as a non-medical person, I truly admire the work that the pediatric oncologist does. And at CHOC, we just appreciate working with you and the members of the SACCSG. It's such a privilege for us. So thank you so much. We really appreciate it. Renee Hicks says, thank you so much, appreciate it. Thank you for your comment, Renee. I think we all agree. And then this video will be loaded on YouTube if anybody wants to view it afterwards. And then on CHOC, on our CHOC website, if you missed the numbers on the screen, we have a refer a child button, which you can also just use. There's also a helpline, which is also manned during office hours between 8 and 4 at 0800 333 555. That is also on our website. And then our next webinar will be on the 25th of May. And Dr. Jasmine Gogo will talk about life-threatening blood disorders. And all of our webinars have been loaded on our website. So you're most welcome to register for those. So thank you again to Prof Geel. Thank you for the work that you do and your passion to make a difference in the lives of children with cancer, not only in South Africa, but worldwide. We really appreciate it. Thank you for everybody who joined the webinar, and we're looking forward to having you on our next webinar. So thank you very much to everybody.
Thanks, Audrey, and thanks everyone for coming.
Thank you.